It's a family clinic. I mean, that's the key. It's not a family therapy clinic. It's not a family mental health clinic. It's a family clinic. So any family referred by clinicians in the Highgate group practice can be seen. And Sue and Irene are members of staff in that clinic, so maybe they should take up the story from there.
We're both sort of links between the clinic and the surgery. Sue's role is as a GP partner, and mine is as practice counsellor in the surgery, and I'm also a family therapist. But I think, just to say something about context, it seems to me that one of the really important things about it is that it's located within general practice, and that family therapy, well, this was Hillary's brainwave, was that family therapy really sits very comfortably and belongs within family medicine, because it means that patients are being referred by their GP to see somebody known to their doctor within the practice within a very short time, you know, often within 3 or 4 weeks. They don't have to go for a secondary referral out. They know that their GP knows us, and we're able to talk to them in a normal, natural way at clinical meetings or in the corridor about the family troubles, and you know, whether it's appropriate to refer them in the first place.
We have a room, a bigger room, with sort of slightly comfier chairs, or we did, that we could fit quite a few people in with some toys. But we don't just see families with children. We often see families consisting of adults, so we don't fit within any particular bit of the sort of sectorisation of mental health, because we're primary care, so we do everything.
The way it started was that my sister lent me a book called Process of Change by Peggy Papp. As a result of reading Peggy Papp and talking to my sister, who said, I know a nice guy called Chris Dare at the Maudsley who runs a family clinic called the Red Arrows. Why don't you give him a ring? So I gave him a ring and joined them and stayed there in the Maudsley Children's Department for several years on a part-time, once a week basis. And while we were there, a sort of intriguing young osteopath by the name of Rob Senior rang Chris and said, would it be all right if I joined the team too? I don't know anything about it, but I'm interested. And Chris, with his usual generosity, said, fine, if you all agree. And we all said, yeah, we'll have an osteopath. And Rob Senior turned up. And we had a very nice time and learnt quite a lot, and then decided that we would meet this need for Haringey and our practice by doing it ourselves, which is what we did. And Myrna Lazarus was practice counsellor and joined us. At first we did it on a very sort of small basis, and then we got more accommodation upstairs in the waiting room and more people joined. And I was, like Sue, the sort of link person with the practice because I was a GP. But later, Rob Mayer, who'd been a trainee in the practice or registrar, joined us because he had an interest in it too, having seen it in action when he was a registrar, and became, when I retired, the sort of Hilary Sue person. We did have a room with a video set up. I have to confess a prejudice. I have a particular dislike for videos and people sitting in other rooms making judgments about families. And I strongly believe if you've got something bloody well to say, you say it in front of the families at the time when it's needed. Anyway, we've had a mixture of people in the team. We've got Irene, of course, who's been with us a long time and was the practice counsellor. We've had other people join from various disciplines, and we've had postgraduate students from the Institute of Psychiatry. And when we were young in the clinic, we did lots of sort of writing and workshops and tried to promote systemic stuff in primary care, which, as Irene says, is the context in which we believe this sort of clinic should live. And I think the practice value it enough to be generous to us since the funding from the authorities has stopped.
It wasn't funded for many years, and then Rob Mayer managed to get some funding from, it was then the PCT, but since it's become the CCG and all of mental health services are very sectorised, and even the sort of primary care health services are adult, child, you know, it hasn't been possible to get any funding. So it's basically just funded by out of the partnership. I mean, Irene's role, she sees other patients as well, or talks to them outside of the times that the clinic's running. And Hilary and Sebastian very kindly just give their services for free. So really, it's only it's a sort of a half a session a week, more or less, for me. So
and a whole afternoon of Irene, but of course Irene is still seeing patients in a different setting.
Yeah. So I mean, it does cost. You know, particularly my involvement, because I'm more expensive because I'm a doctor. You know, so but the partnership really values it because it's such a useful resource for the practice, and we're lucky to have, you know, wonderful Hilary and Sebastian offering their services for free.
I became involved when I retired from the NHS in 2015, having been at the Tavistock Clinic and in a paediatric department nearby the Whittington Hospital. And it was really a revelation for me, having been basically a crypto family therapist paid as a consultant psychiatrist for 30 years, for 35 years, to be actually allowed to come out as a systems therapist in a reflecting team. The reflecting team was a complete revelation to me, and I agree with Hilary. Forget about screens, forget about cameras. To see people talking, to think about it from patient experience point of view, to see people talking about you in a serious but generous, open way is therapeutic in itself, whatever they're saying. If the fact is they're interested. In my view, we are biologically wired to attend to people talking around us in generous ways. So this is a fundamental property. And what Sue says about the team being embedded in the practice is the same, that the patients know that the doctors and the therapists can talk to each other in a friendly way. They don't have to get through emails and protocols and stuff. So there's something very containing about basically an extended family, which is therapeutic.
You two should talk about your current liaison of working with other mental health services.
The crucial link person in this business and in this particular case is the GP. And this particular client has a very caring GP who's willing to link up with the hospital and with us. And when you talk about referring, the sort of medical side actually lies with the GP, who's crucial. And it is a general practice after all. Go on, Sebastian.
Well, going back to an earlier one, we had to refer someone to the Tavistock, which I don't think, it took ages. And I mean, that's my alma mater, but you know, I was impressed. I'm a new convert to primary care, really. I was impressed by the fact that primary care can simply hold cases when everybody else is umming and ahhing, saying, well, maybe not, this is not the right one for us. And the current case that the others are mentioning is also plugged into mental health services, and we have had to liaise with them. It's been quite complex because it was difficult to track them down. But as Hilary says, the GP is the linchpin, the patient's GP, and the GP is not in the family clinic. So we have formed a good relationship, as I would say, a family relationship with the GP responsible. And, you know, what I'm doing now is looking at a screen with faces. That's exactly what we did last week. And we had several mental health practitioners, a GP, and all the team. Sue wasn't there, but Irene, Hilary, and me. And you could see, I could feel that that was a creation of a therapeutic network around this really troubled patient.
I think it is interesting that mental health services seem often, and indeed physical health services, to create professional relationships between themselves and with other bits of their team, but they're not very good always at involving general practice for lots of different reasons. And actually our clinic is always quite a surprise, because they're not really visible what's going on. So I think one of the things about the whole digital platform business is it might make it easier for us to liaise more easily with other bits that are involved in various different clients' care, because it just makes it more accessible, doesn't it?
One of the things that struck me when I joined the clinic was the amount of time, reflecting time, that we have before and after each session. So we aim to have half an hour to talk about the two families that we're about to see, and then we have an hour between, you know, so that we can have a proper post-session and pre-session meeting before the next families arrive. We work in pairs. We agree between us who'll be the lead therapist and who'll be the co-therapist. We get permission for the co-therapist to take notes, and we do explain to families how the reflections will work. And either the co-therapist interrupts, or the therapist will invite the co-therapist to share their thoughts periodically during the session. But we, on the whole, work so that the lead therapist is in charge of the session rather than sharing the session. I don't know if my colleagues would agree with that. I know years ago we had that sort of agreement, and now I'm not sure. I think different pairs may work differently. But I think on the whole, that's how it works.
I think it's fundamental. I mean, that reminds me of how new this was. You know, I've done co-therapy for 40 years, but I've never done reflecting team. And the difference is so obvious that you have to talk to your reflector at some point, at many points, whereas co-therapists do not have to talk to each other. They may just talk parallel to the family or whoever they're seeing. And that it creates another level of discourse, which I think is very, very powerful. And I mean, in a way, you know, as Sue says, we're now creating reflecting teams online, which we won't lose. We'll keep those, even if we get back to meeting in rooms.
But Sebastian, the other thing I think that's really important about having a lead therapist and a co-therapist is that the primary relationship that the client has is with one person rather than two people, and the fact that the co-therapist isn't engaging the family, I think frees the co-therapist up to be much more creative in their thinking while they're present in the session.
Well, that's very interesting. I hadn't sort of put that thought together before. Thanks, Irene. That's right. Mm.
Well, it is a supervisory role in the room without the usual. I mean, when I started in the 70s, you know, we had people phoning in and stuff like that through a one-way screen. So you get this sense of, oh my God, who's that behind the screen? Who knows everything? Well, the person who knows everything is sitting in the room right next to the therapist. And they can see for themselves that we're all of a certain age. I mean, sorry, Sue, I know you're younger. And I don't know, Hilary and I are older, but you know what I mean? None of us is a student. None of us is a student. They can see we're all grown-ups looking after each other. But there is a hierarchy that Irene has introduced between the reflector and the therapist, which impresses the patients, I think, quite a lot, if they actually want to listen, and I think they do.
And I think it works because we want it to, because we've got good mates, because we enjoy it, because we have fun, because it helps the practice.
That's right. I think it's very much sort of personality dependent. It would be a difficult service to set up, I think, within a general practice without there being some GP involvement, because it is so primary care, family sort of orientated. And the problem is general practice is so busy nowadays it sort of feels like it's getting harder rather than easier.
But of course, it was even when we were seeing families from other practices, we were aiming to invite the GPs in to learn and be part of it. And what happened? They just wanted us to see the families and were never part of it in any way. I think you can't start something like this unless you've got an enthusiastic mate to do it with. You've got a supervisor who's enthusiastic, who help you, and you enjoy doing it. And of course, the enjoyment is partly through thinking systemically and realizing that your family's problems are not yours, and you get a unique opportunity to look at the family process in a way that GPs probably normally don't.
I think we should say something about what we mean by systemic, because we are four quite different people, and other members have come and gone, and there's one possible new member coming with different trainings. And I think what makes it work is that we're really interested in what each other has to say. And I often say, oh my goodness, I haven't seen it that way. And I confess to thinking, oh, this is somebody bursting my systemic bubble. You know, I had a formulation in my head somewhere and somebody else, okay, all right, let's. So I have become, I think, a better clinician because I'm listening to others. You know, consultants get treated like gods, which is not good for them. And they're neglected because nobody supervises them. So I gained a lot from the supervision. But clearly all of us do. And I mean, my origins were in Minuchin and Milan and Bing Hall and co. A lot of strategic, systemic stuff, structural, and it's there. But I mean, I'm learning from the others that there are different ways of doing things. And I don't think we've ever had any serious falling out. I can't, no, I mean, I say I don't think, I know we haven't. We've had proper differences, but they're not insurmountable. They're actually encouraging and enriching. I think it's worth saying that.
I'd also like to say, though, Sebastian, that you know, you're very humble about what you bring to the clinic. But firstly, it is actually very useful to have a child psychiatrist in a family clinic, and we do, as it is, to have GPs, you know, knowledge and experience in all sorts of ways. But you've also really validated, because you've come in from the outside after, I know, a sort of relentlessly demanding NHS career, you have actually come in and shown an appreciation and a validation of what we do that actually no one else has done. You know, we've had students and we've had other people working in the clinic, but maybe because you've got the authority that you have, I think it's cohered us as a group. I think we've become a very cohesive group.
And I should say that we're all accredited systems therapists. I think that's quite important. There's nothing amateur about this. I mean, we do feel true amateurs in that we love doing it, but it is actually, there's quite a lot of skill that goes into it. But I think it's also a bit surprising to me that reflective practice in systems does not seem to be big business. You know, Anderson's sort of become a kind of side issue. So I think that not only is this kept going by enthusiasm, it also seems to be keeping something going which isn't mainstream, probably because it's too expensive in terms of personnel.
I think it's important to say that even though we work very comfortably together, we are not worried at all about challenging one another's thinking. And it's very regular that we disagree in front of families about what we've heard or seen, which is important for families to see that we can collaborate and disagree.
We model disagreement, don't we?
Yeah,
We model,
thank you. That's perfectly said, Sue.
Yeah.
I think we are very ready to invite families to help us out. You know, if they're bringing something, a difficulty that we actually don't know about, that we haven't met before, I think we'd be very ready to say, you know, we may need you to help us out here. If we, you know, if we get something wrong or you feel misunderstood or uncomfortable, could you please help us out, help us understand?
We think quite a bit about gender, but that can be, it can be very useful to pair a man and a woman when we're working with families. But we don't have very much, there's not even that much age diversity really. So we certainly don't have any colour diversity, or so there is something, we do think about those things when we're seeing families, and we do quite often discuss them.
And we would you know, refer, if we were sitting with a black family, I think we would refer to the fact that we're a white team, and we hope that that feels okay, but that there may be things that we don't understand, that we don't get.
One thing to mention that I started with, and maybe needs amplifying, is the letter which families receive on referral. Sue, I think, was key in composing it. It doesn't say anything about therapy. It doesn't say anything about mental health. It says, Sue, I think, doesn't it say, bring anyone in your family who you think could be helpful, anyone you want. So it's actually an invitation to systemic thinking on the part of the person seeking help. Already, they're already being inducted into an idea that there are lots of different ways of looking at things. I do feel quite evangelical when we have people coming to see how it, because you can't explain what a reflecting team is, never mind what a family therapy is, until they've seen it. And so they do go away realizing that there's a whole area of clinical experience which they knew nothing about. It's a bit like interviewing us, you know, that we have to realize what we do and not what we know, rather than just assuming that it's understood.